Oh, Joseph, ready to start?
Yeah, sure.
Okay, so welcome everyone. It's another Sunday, and I have a case for Joseph today. So everyone sit tight and learn from Joseph. So, Joseph, today we have a 45 years old female who presented with bone pain for 7 years. I think we can start from there.
Yeah, thank you very much. Um, Bone pain. Uh, I should say that it's something that I can't say I have an approach to it. But the way I've seen patients, the moment they come to me and they say they are bone pain, I listen twice because what they think it might be bone, probably it's not. Probably they have a muscle pain. Some of them they even have just joint pain, and then yeah, things like that. But so the SPI will tell us if really this is bone pain, and if you don't have an approach to something, you can try to make one around here in real time. And anatomical approach is I think the easiest. So bone is painful. Pain is a sign of inflammation. Probably bone is inflamed. So what is the thing? So you also think, what does the bone contain? On the outside, there is this periosteum, and then in the from the periosteum you have the bone itself, which has minerals, and then inside you have the marrow. So from the periosteal reaction itself, anything depriving poor blood supply from the periosteum can cause pain, and then all causes of demineralization of the bone can cause bone pain. You all have seen patients on dialysis. They have um, uh, the 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 CKMD, I think the chronic kidney disease, mineral bone disease, CKDMBD. They have bone pain because of the demineralization of that of the bone itself that's coming from. But from the inside, um, think of patients with sickle cell. They also have bone pain because as a poor blood supply from any organ in this patient can have pain. But things that we see usually, and also going to include them, include uh, people with multiple myeloma, for example. So again, this will be an infiltrative malignancy to the bone, which causes also bone pain. So uh, I have to see around uh, what's going on in this folk because this is quite some time, 7 years. So it won't be a disease like a cancer, that I'm sure, but demineralization, very possible. Um, Again, anything to sit for this long, few things like osteomalacia, probably, but the edge doesn't look like that. So I have to listen what David presenting the HPI and see if I can go to the roots of what's causing the bone pain for this quite this long. Thank you.
That's very interesting. I feel like you're making the history useless because you almost are preempting everything. So anything that causes demineralization, I think I'm already learning a lot. Anything that causes demineralization, and then you mentioned myeloma, you mentioned sickle cell, and the anatomical approach, starting from the outside to the inside. Yeah, that's very impressive. So we go on to the HPA. It's just a short one. So the bone pain was of gradual onset. It was involving the lower back, which was the longest, 7 years, and then left thigh for 5 years, and then right arm 2 years. It was dull aching with a score 4 to 6 on a scale of 10. It was on and off, worsened by activity and movement, partially relieved by analgesics. And 1 month prior to presentation, She experienced a sudden onset of pain and an inability to use the left lower limb, and that came after twisting while walking on level ground. And this was followed by intense pain, swelling, and inability to bear weight. And so, around the very same time, while the patient was on transit, was in a car, she experienced the sudden onset of pain, swelling, and inability to use the right upper limb. And this was after abrupt car braking, which led to extending the arm and hitting in the front car seat. However, there was no bleeding or changes in sensation. She denies fevers, night sweats, or weight loss, no muscle pain, joint pain, or stiffness, or ulcers, or skin rash. She has no palpitations, easy fatigue, bleeding tendencies, abdominal pain, constipation, urinary frequency, or increased thirst. So the review of systems was unremarkable. Past medical history unremarkable. She has no chronic illness and she's not on any medications. The family social history was non-contributory, and that's it about the history.
Yeah, I should say it's a pretty much interesting history, to which is a completely new land for me. Probably never took care of something like this. But we'll see. As we say here, it's not about the diagnosis, but how you approach it. So let me take a little bite of the information that is being presented here and see if I can make progress. Now, the most important thing is what happened on the day that the patient presented to the hospital. And inability to use a limb like abruptly, it can make you think things which happen abruptly. It can make you think maybe it's a blocked vessel, but you realize no, that's not true because this person is also having pain. Can I see that slide, David? He's also having pain. So I'm having an idea here that this patient had a trivial fracture, and the X-ray will prove me wrong or right, but that's my idea. And also the subsequent incident that happened to the other limb can be the same thing because as I'm seeing here, that there was a breaking and then the limb hit something and then the same thing happened. So probably this patient had a trivial fracture and then moved back, bone pain. And if this will turn out to be anything else, I have to completely change what I'm thinking. But if it will be this is a fracture and there is a bone pain, these are very brittle, weak bones this patient is having. And it will go back to what I thought initially, a demineralized bone, making it so weak that it can fracture trivially, like this. Do I have anything else? I think much will come from the investigation in this case than the history, the way I'm seeing how it's going. And again, I keep going back to what is that thing that can live with you like 7 years, and for 7 years you live with the disease, and then you start having the end result of the disease that the bones are probably breaking up. Still, I cannot figure it out. I think I'll be thinking about the case as we move on. But the most important thing in here, I believe this patient was being presented here on the day of presentation. What made them to come to the hospital is this sudden disuse of the limb following pain, which can translate into a triple fracture. Um, so the next slide. Yep. Okay. Yeah. Yeah. So other things that are here, if someone also tells you they have pain, bones is something that is everywhere in the body. So another thing that you should think before like saying it's really is the bone, because patients might say bone and then you have to translate it. Other things that sit everywhere in the body include muscles and then vessels and then I think nerves. So all these things, if they are diffusely affected, like a disease diffusely affecting the muscles, a disease diffusely affecting the nerves and causing nociceptive pain. They can also present with pain everywhere. Yeah, but that's a digression. I was trying to think initially. I should have included in the chief complaint, but I think we should see more slides and see if I can come up with anything.
Okay, so we proceed to exam because we have seen other components of the history. So on general exam, this patient was fully conscious. She was pale, not jaundiced, no lymphadenopathy, no lower limb edema. All vitals were within normal limits, and the waist circumference was 163. So weight and height were not able to be, were not taken because this patient has pain and therefore she could not bear weight. So it was just the waist circumference that was taken. On systemic exam, we had positive findings on musculoskeletal system exam, where the patient had tenderness on the right upper arm with limited range of motion at shoulder and elbow joints, but she had intact pulses as well as sensation, and the contralateral upper limb was completely normal. She also had a tender left thigh. The limb was externally rotated and shortened as compared to the right lower limb. And she also had limited range of motion at hip and knee joints with intact pulses and sensation. The rest of the physical examination, including neuro, so neuro was limited, especially motor examination because of these slightly because of the tender limbs, and therefore movements were not, especially power was not assessed well in these limbs, but power in the other limbs, tone, and everything else was normal. Cardiovascular, respiratory, as well as abdominal exam were all normal.
Hmm.
Back to you, Joseph.
Yeah. So before I proceed, I should ask: is that waist circumference normal?
Also, waist circumference, that one is increased for a female. I believe the upper limit is 88 centimeters for females, and it's 100 and something for males, or 90 something.
Okay.
Yeah.
Yeah. So that's helpful. Um, so going back, I think there was a mention then the issue just say this patient is also pale, right? Can I see the physical, the general exam? Yeah. So there's a mention the most important thing. Two things come up in this slide. That is, this patient is also pale, and then there's increased girth, the waist circumference. Um, so you see bone pain, anemia, which is this pale thing, and then someone starts thinking of the triad of the I think not the triad, it's the crab mnemonic of multiple myeloma, which says yeah, calcium, anemia, bone, and then calcium, renal, anemia, and then bone. Yes, so it's also the two are already there. But again, multiple myeloma for 7 years without treatment, probably, but less likely. And then even the age doesn't go into that direction. So, what are the other things that can cause this anemia? And then you have a bone pain. I will think about this waist circumference of 163 that you're saying is probably increased in a female. Uh, might be translating and making a reflex thinking here that the abdominal circumference is big. There's a lot of demineralization for quite some time to the point that these patients have trivial fracture, like on the very strong bone, like the bone, like the femur. And then the thing that comes to mind reflexively, and I've seen a case, is I think excess cortisol in the body. So excess cortisol in the body. Why? So maybe we were not told in the history about the medication history. Probably she's on long term steroids, maybe. But if we prove she's not, we have to test this. Probably she's producing a lot of endogenous endogenous steroid from the suprarenal gland. So that will be one of the case that I should. I'm starting having things that I know I'm going to test in this patient maybe later. Although we're not told of other things. Where if we see these patients, we look at their skin, we can see they have easy bruising. They have, like, you can see the vessels going around. But is it necessary to see that? Maybe it's not. And I'm also thinking of other things here. I think no. The systemic exam is the most important thing that is being shown there. Is that like we are having evidence before we perform an X-ray that this patient had fractures. So if I define my problems, I'm having a chronic illness involving the bones, a chronic illness involving the bones. On top of that, this the patient has anemia, and the waist circumference, probably maybe the uh, patient is just obese, or they have that sort of thing, and it's not related. But if I see, I can tell if this is just normal obesity or it's the central obesity that we are defining here. So I think we should proceed by those things. I have them in mind. The On top of it, I'll put their excess cortisol in the patient's body uh, from maybe endogenous production of the hormonal excess. I mean, use of long-term use of steroids. Multiple myeloma, it's likely 7 years, and in a 45-year-old female, maybe, but less likely. Other things I talked in the first slide about osteomalacia. Yeah, I remember reading, and then I had a case that I suspected it, but my reading failed me because it seems like it shouldn't happen in Africans. And then the age is so super old. These white folks, they are very old, 60s, 70s. They get the thing. Yeah, so I think I'm right there, David. Maybe we should see other things.
Yeah, thank you, Joseph. So I'm just trying to backtrack on your thoughts here. So I think a lot of things to be learned. So for those who are listening, I'm not sure if you are trying to also think quietly what are your thoughts, but as you can see, so one problem of bone pain, and then lots of differentials, some of which are many feet apart. So, for example, you have an issue of multiple myeloma, sickle cell disease came up at some point, osteomalacia along the list, and then we're also having hypercortisolism. So you can see some hematological diagnosis came up, some endocrine diagnosis coming up, a lot of thoughts, and I'm not sure if there is a better way to teach clinical thinking than this one. I'm not sure. So we'll proceed to to the labs, and here is what you have. So I highlighted the grossly abnormal ones for ease of picking them, but we have a CBC with so what was abnormal here was the hemoglobin, which is 9.08, normocytic, normochromic, urinalysis, ESR, CRP, creatinine, BUN were normal, other electrolytes normal, cortisol, which you are thinking of, was normal, a thyroid panel was normal, and then we also have an elevated calcium level. And then I think I had some images. So before I let you discuss on those labs and these images, you can look at them and comment if you see anything of interest. So I'll stop there and let you discuss those.
Yeah, can I see the labs again? I think the two lab abnormalities, these are super important here. Yeah, so the anemia that we've been told in the history turns out is 9, and this is a mild normochromic anemia. I've said here sometimes that the way of thinking macrocytic, microcytic, normochromic, it's a way of remembering, but sometimes they cross cut. But we start with it. Normochromic anemia. Think of two anemia first: anemia of CKD, and then anemia of chronic illness. But anemia of chronic illness. If you say anemia of chronic illness, the rule is you have to rule out other causes of anemia. So in a patient like this, even iron deficiency anemia can be normochromic sometimes, although it should be microcytic. So you should just send the ferritin. So if at the end we'll say, okay, there is no any other cause that we're seeing is causing anemia, probably this anemia of chronic illness. And another principle of anemia of chronic illness is usually mild. It's never moderate or severe. Sometimes patients have both. They have a chronic illness, they're not eating well, they have an iron deficiency anemia and anemia of chronic illness. They'll go into the mild, mild moderate category. So another very important thing here is the calcium of 3.8, which is hypercalcemia. I believe this is a total calcium. Yes, this is a number for total calcium. No. This is ionized, David, that I know, right? This is ionized calcium. Yes, the total is 8 to 10 normal. This is ionized. So this is ionized calcium. Very good. We don't have to know the albumin so that to calculate what's not that. So truly, this patient has hypercalcemia. So my approach for hypercalcemia, we'll start with thinking of the normal physiology of calcium. So if you think of calcium, you think of, I think, like three things, and that is parathyroid hormone, vitamin D. Yeah, so parathyroid hormone, vitamin D, and calcium itself, which is, you're talking about the bonds here. So the causes, if you break them down, of hypercalcemia, you go into those which are caused by elevated levels of parathyroid hormone, and those in which patient have a normal level of parathyroid hormone. So the hyperparathyroid causes of hypercalcemia, these will include things like primarily hyperparathyroidism, a parathyroid tumor sitting there secreting a PTH, parathyroid hyperplasia without a tumor, just the four glands being hyperplasia, and then they secrete a lot of PTH, leading to bone resorption, causing hypercalcemia. And so in this patient, we must send also, when you see a patient with hypercalcemia, you send a parathyroid hormone, because that's where the cross-cutting causes you are going to get them. But on the other hand, what are those what about those causes in which the parathyroid hormone is in normal level or lowish level? And on this side, I think we have one is called parathyroid hormone I think it's PTHRP. The RP, I think, is yeah, it's a protein that looks like parathyroid hormone, but it's not parathyroid hormone. And usually it is produced in the body by some cancers, which include squamous cell cancers of the lung. So you have a patient with lung cancer, and then they have they have hypercalcemia. So you test this PTH is normal, but you send the PTHRP becomes elevated. You say this is it's usually the yeah the cancers which secrete that secrete other substances. There's a category of those diseases. I think paraneoplastic. So it's a paraneoplastic disease, paraneoplastic syndrome. The other cause of hypercalcemia with a normal level of PTH would include things like excess vitamin D. You have these patients nowadays, they say they have been reading on the internet, they think they are malaise, they think they have vitamin D is low, they come also they have an injection of vitamin D, they can have hypercalcemia because of excess vitamin D. Other causes now will include anything that can resorb the bonds. As we know, if you resorb the bonds, you increase calcium because you resorb the bond, calcium goes into the system, and your ability of kidney to excrete calcium in a day is limited, so you end up with hyperparathyroidism. And these include bone metastasis from cancers. In the metastasis in a female, from breast, for example, but or from, as we talked before, multiple myeloma. Myeloma is of concern here, but again, I wouldn't consider it high up in the top in a 45-year-old female who was living their life for 7 years. Maybe, but I wouldn't consider that first. Put it down. And another thing, here we emphasize about diagnosis, but again, if we see an opportunity to teach about management, is very important. You see a patient with calcium this high, this is ionized calcium. If this was total calcium, the number would be very huge, it will scare you. So I'll be giving this patient a lot of fluid right now because, calcium is among the dangerous electrolyte to have it high like this. So you give them a lot of fluid and see what's happening. Yeah. Cortisol, the serum cortisol being normal doesn't rule out hypercortisolemia. You have to test, and it's not the morning cortisol. It's not the morning cortisol. The morning cortisol is for testing, the hypocortisolemia. So to test the hypercortisolemia, i.e. Cushing, you have to do, I think, this is the dexamethasone stimulation tests, and I did it once with a very intelligent general practitioner at one hospital, which we injected the dex at midnight, and then we measured it in the morning, and that patient, I remember, ended up with a Cushing. So still, I put it that this patient can be having still hypercortisolemia, probably Cushing, probably, but not known still. Yeah, the what I saw in those X-rays, David, is highly resolved bone density. Look at these bones. This is a 45-year-old. This is not the bone of a 45-year-old. So as we were saying initially, there is a lot of bone demineralization going on, and this X-ray also shows how the abdomen of this woman is. And I wish it, so the picture, but kind of looking Cushingoid somehow with the central obesity. Yeah, so Cushing is on the top here. Having a normal cortisol level doesn't rule it out. In the patient who looks like he's if I connect the dots, and so if one might ask, so you have Cushing, how you end up with hypercalcemia and bone resorption? It's because the Cushing cause increased bone, the hypercortisol caused increased bone turnover. So increased bone turnover, and then uh, you have all these sort of things the patient is presenting with. Yeah, I think we should proceed.
Thank you, Joseph. And just to point out on this, and the cortisol that you are talking about, the dexamethasone, I believe you meant dexamethasone suppression test, because you are testing
Yeah,
for hyper,
yeah, yeah, yeah.
yeah, and not
Yeah.
so suppression test. And so additional details is these X-rays are also showing, although the quality was not that good, there are fractures here. So you can see a discontinuity. I believe you can see my cursor.
Yeah, yeah,
So
sure.
on the left here, so there is a fracture here on the almost the neck of the femur. And then also on this image, you can see that there is a loss of discontinuation on the humerus, uh, just below the head
Mm,
at this point here. So there is a discontinuation. So there are some fractures also.
sure.
Yeah. So we proceed, and I have some more labs for you here, some extra labs, and I believe after this you'll have to commit to a diagnosis.
Yeah. So, yeah, thank you. Pretty interesting. Sorry, I forgot to. Yeah, the reason we took the X-rays because this patient had pain in those teams, and then I was taken away by the resolved bone rather than the fractures themselves. But thank you for showing me. So yeah, this is a pretty interesting lab and straightforward. I'm not even starting with that LP, but the most important thing here is the S paper, which is normal. But you know, a normal serum protein electrophoresis doesn't rule out multiple myeloma. These clinicians pretty intelligent. They did the kappa lambda, and you see that ratio there around 1, which is the normal. Because some patient might have maybe like light chain myeloma. The light chain myeloma, SPEP can be normal. And then you do the kappa lambda ratio is high. Still, multiple myeloma, uh, even if the SPP is it looks normal. But in this patient, so we can confidently say this patient doesn't have MM or any other plasma cell dyscrasia of that sort. Um, Another thing is the normal vitamin D, pretty cool lab to do. And as I said, it can also cause hypercalcemia, so we've been ruling that out. That ALP, David, is the alk phos, right? Yeah. So the alk phos being elevated this high is not surprising. The isolated ALP elevation, you should think of bone. If LP is elevated plus other liver enzymes, think of the liver itself. But if the other liver enzymes are normal, elevated ALP on its own, think of the ALPs coming from the bone, especially if it's this high. I remember having a patient with this patient had a skin cancer, and which she didn't even care. She thought it's just a normal wound there. And then in the lab there was ALP. It turns out that she had a cancer of the skin plus Mets already at that point to the bone. So it was that case was awakening to me. So these labs, the ALP doesn't add anything. We already know what's happening to the bone. But the most important thing in this slide is the normal SPP and the kappa lambda ratios. So still, I think if I look inside, I remain with the diagnosis of Cushing. You know, hypercortisolism is one thing. Cushing syndrome is another. There is hypercortisolism, but there are those features and waves. looking at that X-ray, I believe this patient doesn't have ascites. Those are facts. So there is a central obesity. So has to be a Cushing syndrome. And as David has reminded me, you have to do an overnight DEXA suppression test where you inject, I think, 1 milligram or something. Then you take the morning cortisol next day, the next morning. Any other differential diagnosis from that? I think, let me see. Yeah, I said osteomalacia, pretty unlikely in an African, and doesn't look like it. Another thing that I shows, if this turns out to be Cushing, the journey is not over. Then is where is it coming from? And a huge percent of it, I think David will correct me, but I think it's like 80% is primary Cushing syndrome, where you have maybe a tumor on the suprarenal gland producing that Cushing. But you can have secondary in some sort of patients, or even tertiary. Secondary is from the brain, tertiary is from like something which is out there. You can maybe something in the muscle or the liver producing the cortisol. Yeah, so I think David, my diagnosis would be Cushing syndrome in this case.
Thank you for the interesting discussion, Joseph. So, just before maybe I ask some follow-up questions, can you summarize what we've been discussing so far? Because I believe some colleagues have joined where we had already covered the history.
Yeah, we are having a very interesting case of a 45-year-old female who has been troubled by 7 years of bone pain. And on the day of presentation, the patient presented with acute onset of failure to use one of the limbs, followed by when she was being transported to hospital, she hit herself on the dashboard when the car hit brakes, and then she had another painful swelling of the upper limb, and which both of them translated into trivial fractures, as we've seen in the on the X-ray. On exam, we saw she was pale, and the HB of 9 proved it. And then she also had increased abdominal circumference. So yes, two most important labs: anemia of 9, hypercalcemia of 3, ionized calcium. And yeah, the X-ray showed highly resolved bonds with the two fractures that I mentioned before. And yeah, I think that also the investigations for multiple myeloma, they are negative, like you're seeing here, with this high elevated ALP, isolated elevation in ALP, alk-phos. Yeah.
Thank you, Joseph. A good summary. So, what I haven't told people is I think calcium is one of Joseph's favorite lab parameters. Should I say an electrolyte? I know when we talk of electrolytes, many times we talk of sodium potassium chloride, but then I think is one of Joseph's favorite cations. So, Joseph, I just have some follow-up questions. You've correctly discussed that the issue of the hypercalcemia, and I think I cannot overemphasize that Joseph is very comfortable with calcium. So the issue of the Cushing's, are there any other features maybe from the history of from the physical exam or with these labs that is convincing you that most likely this patient could be having a hypercortisolism? And by the way, so Joseph picked up the severely reduced bone density, of course, with the limitations of an X-ray. But I think I forgot to mention one piece of information, that this patient was actually was transferred to Moi, and they were trying to fix, especially the femur fracture with by doing ORIF, but then uh, the bone could not just hold the nails, so they thought that the bones were very brittle, and or referred the patient for further investigation. So, Joseph, is there anything else that is very convincing for you that this increased bone turnover that we see is from Cushing? So, do you have any other thoughts?
Yeah. So apart from the central obesity, I don't remember if anemia is in that category. I don't even remember. But let me see. Yeah. So apart from central obesity and the resolved bonds, anemia is questionable. I don't think if it's in there. We haven't. You haven't told me about. You haven't told me about her menstruations. So those also include this patient misses menses. Another thing that they have neuropsychiatric symptoms. They have insomnia. They have mood changes, and then again, I didn't hear them that coming from the history. Also, if you examine them, apart from seeing the central obesity, you can see they have a buffalo hump. They can have like there is no fat below the skin, like the absent fat, but below the skin is skin and then the muscle. And you can visibly, if they are of a fair color, you can visibly see the vessel. So I don't know. The way you presented from the central obesity and resolved bonds, those are the other things that I could have asked or looked. I don't know if they were there, David.
Thank you, Joseph. So I'll post some more pieces of data here and reveal the final diagnosis. So at some point you talked about the PTH. Um, so the PTH was highly elevated, 2300, with an upper limit being 80. And then I'll also show some images which were suspicious of a mass in the thyroid area. And so after this elevated PTH and the imaging that will show this patient went so for surgery and tissue was taken, and the conclusion was a parathyroid adenoma. So here are some images, and of course I have to admit that I myself am not sure exactly what we are seeing, but so the ones who saw this patient, actually this was an iterative process. They had to go back and forth and then came and asked the radiologist, and they concluded that what we see here, these are it was some suspicious mass in the thyroid area. This one in the other, the sagittal section, where my cursor is moving around, and the central area looks almost necrotic. So this patient underwent surgery, and so tissue was sent for histology, and the conclusion was parathyroid adenoma. So we had a final diagnosis of primary hyperparathyroidism. So this patient was presented at a grand round, and I thought it's interesting, especially knowing that many people are not very comfortable with calcium as a cation, and I thought this would be a very good opportunity for Joseph to teach you about calcium, and he already did. So I just have one slide, and I think this will be more of a repetition because Joseph has talked about it. So when you come across hypercalcemia, I think just think about two major categories, whether it's PTH dependent or PTH independent. And PTH dependent is when you have in like primary hyperparathyroidism, where you have an elevated level of PTH. So practically speaking, if you see an elevated level of calcium and you make sure you are dealing with hypercalcemia by correcting it if that is necessary. The next thing is you order a PTH if you just wanted to if you do not want to take the long cuts. And if you see the PTH level is elevated, then you know you are dealing with primary hyperparathyroidism. And of course, the journey will not be over, because you have to know, are you dealing with an adenoma, which is the most prevalent. You're talking about 80%. And then the rest is, for example, you can also have a parathyroid carcinoma, a malignant tumor of the parathyroid glands. And uh, PTH related peptide, which Joseph has talked about, is released by a number of malignancies, and it also leads to an elevation in calcium. So when we talk of malignancies, a number of mechanisms here. So some malignancies, if you remember, Joseph presented to me a human DX case. I think it was sometimes last year, a patient who turned out to have a chondrosarcoma with metastasis to bone and lungs. The patient had a miliary pattern on a chest X-ray. So with malignancies, you can have metastasis to bones, in which case you will have increased bone turnover and elevated ALP. And so that is one mechanism. The other is through PTHRP. So others which are PTH independent. Now in these patients, you will order your PTH and it will be normal or low, because calcium, so there are calcium sensing receptors in the parathyroid glands, and therefore there is a negative feedback mechanism. So an elevation in calcium leads to suppression in PTH production. So in PTH independent hypercalcemia, you'll have a normal or low level of parathyroid hormone, actually a low level parathyroid hormone. So other causes are like milk alkali syndrome, which were common in there of taking antacids, which contain bicarbonates and lots of calcium. Vitamin D excess. Remember, vitamin D was done in this patient. So if you hear, and I think I discussed it in that session, where you can have hypercalcemia due to excessive vitamin D activation by granuloma. So tuberculosis can cause that. Sarcoidosis can cause that. And you can also have hypercalcemia from increased vitamin D intake. And another one is increased bone turnover from a number of things, hyperthyroidism, Paget's disease. I think someone mentioned that differential in the chat. Vitamin A mobilization, and many other things. So I think calcium is an interesting cation, and you need to master it. So I thought I'll just do teaching points in this one slide, and then let Joseph reflect on it. But then each one of us to go and familiarize ourselves more with calcium, and then maybe read around all sorts of hyperparathyroidism. So back to you, Joseph, for reflections.
Yeah, thank you very much. This is a pretty cool case, and yeah, reflection is the most important part of any case. Yeah, reflecting on myself, I was carried away with what was presented as increased abdominal circumference, thinking is central obesity, and did what we usually call here premature closure. Yeah, but in real life, wherever someone sees hypercalcemia, they send a PTH first of all. So yeah, it comes back and you go on the side of hypercalcemia because of elevated PTH. You won't find Cushing there. So yeah, it will be easier to arrive at the diagnosis than here. So yeah, we shouldn't jump to conclusions. just because of just one piece of information like that increase the abdominal circumference. Otherwise, thank you very much. Electrolytes, David, I'll tell you, is the thing that I don't know why, but usually you go through residence, you go through medical school, maybe absent at all because these folks maybe won't see these things. But even in residency, you just brush around them. But if you come and think about them, they are pretty cool. They have a very good physiology. It's easy to understand. Like calcium, I don't even remember the last time I saw hypercalcemia, but it's because of the physiology, it's easy to follow. So I would encourage everyone around here to know this, not just calcium, sodium, potassium, etc. Thank you very much.
Thank you, Joseph. And so I think I've learnt a lot from presenting this case today on the way you approached it. And when I was summarizing the case, as I said, I did not attend this patient. This patient was attended by some brilliant residents and one physician who saw the patient after the patient was referred from Moi after failed ORIF. So they referred the patient with thoughts of probably a bone malignancy because the bones appear to be very brittle. So the patient was presented in a grand round, and I thought it will be a good case for learning. So that one piece of information on the waist circumference, when I was summarizing the case today, I almost omitted it, but then I thought, okay, I think this will be a missed opportunity if I omit it, so I included it. And I believe that every one of us can appreciate how tough of a job is clinical reasoning, because you have multiple pieces of information, uh, a number of diagnoses that can explain a constellation of symptoms that you have at hand. And a piece of information can either lead you to a diagnosis or sometimes derail you, just like what happened with Joseph here. So the obesity, and of course, he of course I what I saw is that Joseph had all the answers, because at some point he was considering, in order to avoid biases, he was actually entertaining multiple thoughts at the same time. So, for example, when he was talking about the central obesity, he said that this obesity, of course, the central obesity that we see could be because of the hypercortisolism, but it could be that this patient is having obesity, is just having obesity, and then this is another separate pathology. So oftentimes we find ourselves at crossroads where you have a syndrome that can be explained by a certain pathology, but then we talk about these heuristics here multiple times. We have Occam's razor, where you try to find one pathology that explains everything, but we also have Hickham's dictum, where we say a patient can have as many diseases as they want. So this is one of those cases where you have brittle bones, hypercalcemia, and you also have central obesity. And these are not explained by Cushing's, but rather the patient is having obesity and is having hypercortisolism. So I think I've learned a lot from Joseph and from the case. And thank you very much, Joseph, for discussing. We are still on time. We have a minute. So if anyone has anything to share, a question or comment, please welcome. I do not see any hands. Joseph, is there anything before we close?
Nothing. I just encourage other people to volunteer and discuss. It's not difficult. You're not exposing yourself. If you the diagnosis okay, like I've did today, and volunteer to discuss the case. It makes it more fun if several of us, we have different flavors from different people from different places. Yeah, just that.
Thank you, Joseph. So I see a hand from Kefa. Please welcome. Hello, Kefa. I see your hand raised. If you are speaking, you are muted. Can you please unmute yourself and
Okay, yes. What I want to say is to say thank you for the nice presentation. Only that.
thank you very much. We appreciate that, and we look forward to, just like Joseph said. I hope that next time we have other discussants and people showing up with cases, even cases which do not have final diagnosis. So I should commend Roland. So we have a pending case from Roland. We are still working on it. And that is on my side. He already shared the case. I think I'm doing some final touches and will present here in the recent future. He also reached out to me today that he has another case that is finalizing, and will also present that. So I call on everyone else to, if you have cases that you find interesting and you think we can learn from, please feel free to share them. And we also wish to have many discussants so that we can learn from multiple people. So please feel free to uh, to 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 come forward and discuss cases so we can learn from you. Sengua, please welcome. I see you have a raised hand.
Thank you very much for a very brilliant presentation. The case was really interesting. I just wanted to know if you are still following up this patient. I know you said you are not a primary physician for this patient, but patients who undergo parathyroidectomy, they need a long-term follow-up because they can get an hungry bone syndrome where you have severe hypocalcemia resulting from the surgery, and they can actually deteriorate, and they may need long-term supplementation of calcium and vitamin D. So I don't know if you have any follow-up after the surgery to know whether the patient is eucalcemic.
Interesting questions, Sengua. So yeah, this patient during surgery, or many patients, normal variants, they have 4 parathyroid glands behind the thyroid. So this patient, it was two of the 4 glands were removed, and so after surgery, this patient had a brief episode of hypocalcemia and was supplemented with calcium, but then afterwards, the remaining glands are kicked up, and she became eucalcemic, and afterwards she has been doing well. No more episodes of hypocalcemia.
Yeah, that's great. Thank you.
Thank you very much for the question, and I hope people have also learned from it. Hungry bone syndrome. Okay, so if there are no further questions or comments, thank you very much, everyone, for joining. We hope to see you again next weekend. Have a good night.
Good night.